Good day, all, and welcome to the Teledyne Pulse podcast, your Rural Health Matters resource. Hear from your colleagues and industry experts on rural health issues and innovative care models that make a difference for rural hospitals, providers, and communities.
Welcome to the Teledyne Pulse podcast. Shane, we've got another great guest with us today, Congressman Mike Flood. Excited to hear what he has to say about rural health, rural hospitals, and I will pass it off to you.
Excellent, Andy. Yeah, honored to have the Honorable Congressman Mike Flood with us today, and excited that you've taken time out of your busy schedule to meet with us today and just talk a little bit about rural health issues and a couple of issues that perhaps haven't been either thought about before or at least haven't really been in the limelight. So I'm excited to bring some of this information to the table and get your perspective on not only some of those newer initiatives that you're working on, but some of the stuff related to just rural health care in the state of Nebraska and just a Washington perspective in general. So excited to have this opportunity to get your perspective on things, Congressman Flood. So I thought what we would do is maybe start with a little bit of an introduction of yourself and a little bit about yourself, and then we'll get going.
Well, thanks, Shane. Good to talk to you both today. Yes, so I'm born and raised in Norfolk. I represent the 1st Congressional District, which includes all of the city of Lincoln and Lancaster County, Cass County, Papillion, La Vista, Bellevue in Sarpy County, and then Fremont, Columbus, and Norfolk, just kind of 12 counties in the eastern part of the state of Nebraska. Before this, I was in the legislature for 10 years, served 6 as speaker, and in my regular day job career, I'm a broadcaster and a lawyer. So most importantly, I'm a husband and a father to 2 teenagers. I've got an 18-year-old, in a couple of days, and a 14-year-old. So that keeps me pretty busy.
That's excellent. Are they on the political train too, Representative Flood, or where are they going?
Good question. You would think. I always say if my dad were in Congress, we'd be doing this together. But both of my kids are 100% devoted to their high school sports career and the high school experience, and they have shown very little interest in national, state, or local politics. So opposites, right? That's how it's supposed to work.
Yeah, yeah. Well, Representative Flood, I've known you for years, and as well as your wife Mandy, and fantastic family and fantastic just entrepreneurial spirit that you bring to the table, along with several other fronts, particularly supporting Nebraska and the rural markets in Nebraska, like you've done for years. I thought what we would do today is maybe start a little bit about a little bit of a newer angle that you brought to at least to my attention here a few weeks ago when we visited about we were talking about rural America in general and rural healthcare, and one of the things you brought up was related to I wouldn't qualify it as a new area of interest, but isolation and loneliness, which has been deemed really an epidemic by the Surgeon General. And I know that you've taken some action on this and have some insight on this. So maybe we'll start there and talk a little bit about that, and then maybe how you see that impacting rural Nebraska, rural America, and perhaps what the local healthcare environments and hospitals might take up interest in, and maybe how they could be a part of the solution here.
Yeah, well, I appreciate the question because this is something that the Surgeon General has identified as a health epidemic across the United States and really globally. The United Kingdom has been paying attention to isolation and loneliness since 2015. And now in Congress, myself, Senator Chris Murphy from Connecticut, Senator Ricketts, and others are making it a priority. The reality of it is that those experiencing loneliness don't keep up with their medication, they live alone, or they have very little meaningful contact with others, and they isolate, and they let themselves go. And the reality is that after someone enters this kind of depressed phase and they're isolated and they're lonely, they present themselves in an ER, and it costs a lot more to get them back on track. And so what we want to do, I think as a country, is just be upfront about those of more mature age that have outlived their husbands, which oftentimes we're talking about a widow here in her 70s, 80s, 90s, living alone and has very little contact. One of the things I learned is that rural mail carriers or all mail carriers, they'll say that every time they deliver mail to someone who's isolated or lonely, that person will be standing at the window when they deliver the mail because it's really the only human interaction they have during the entire day. And they know that if Alice, for instance, isn't looking out the window, there's probably something that's happened. And they go up and they peer through the window and they can see her legs, in the kitchen, that she's fallen and she needs help, and they call 911. This happens far more than anybody really knows about. So I introduced a resolution identifying the role of loneliness and isolation in public health, really to plant a marker on this issue. And shortly after that, the Surgeon General declared an epidemic of loneliness and published an advisory. I currently have a bill to standardize measurements for loneliness and isolation so we can research this issue. I will tell you, my goal isn't to run in and have a bevy of solutions. My goal is to let's identify what the issues are. Let's identify with definitions what loneliness is, and then engage academia and data and real world experience across rural and urban areas, and thoughtfully approach this with a policy plan. And so there's a lot of work to be done here. I think that critical access hospitals in rural areas are going to be on the front line of this. We make a pretty serious investment in critical access hospitals as the federal government, and I envision them having a very prominent role.
Yeah, I agree with you, and obviously there's 62 or thereabouts. It's right around 62 critical access hospitals in Nebraska alone. So there's definitely a wide distribution of access to those facilities, and they're well positioned to have some sort of play in this, albeit yet to be determined what that ultimately looks like. But it is interesting, even based on the documents that you shared, that the lacking the social interaction or connection actually carries a higher mortality rate than smoking 15 cigarettes a day, or excessive alcohol use, or inactivity, obesity, etc. So it's definitely an opportunity to make an impact, and I think the critical access hospitals are well positioned along with their providers in playing a role in that. So, however, as you build this consortium of individuals to actually have and build this plan, or at least the research around this, having hospital involvement in that, I think, would be important. I do see that the National Rural Health Association is a sponsor organization for your bill on this front, along with several other uh, healthcare institutions.
Well, that's absolutely right. We recently just had our loneliness roundtable, and we were joined by the Nebraska Hospital Association, and we had the CEO from the Franciscan Healthcare Critical Access Hospital in West Point. And one of the things that they told us about the West Point area is that some folks that are experiencing isolation and loneliness will call the rescue unit. There's nothing wrong. They will call the rescue unit, ride it into the hospital, and be checked out just because they want to see somebody. And
Yeah.
they make that call more often than anybody knows. That's the depth of this issue in rural Nebraska, that you would call the rescue unit just to have human contact. There's got to be a better way to make sure that we are connecting with seniors than someone that's so desperate that they make that call to 911.
Yeah, absolutely, and it'll be interesting to see. Although the virtual technology that doesn't necessarily replace the face-to-face human interaction, there may be an opportunity to increase at a minimum the coverage of the social interaction by leveraging virtual technologies of some sort, and facilitating the back end of that in terms of who's on the other end actually conversing with these individuals. But completely agree. In fact, I was in that business years ago, and so actually we were getting those calls, gosh, back in the mid to late '90s already. So it's definitely more prevalent today, but it's been a part of that for a long time. We'll say maybe switching gears a little bit. By the way, that's a very interesting topic, and excited to learn more about that Congressman Flood, as you move forward on that bill. Let's switch gears a little bit and talk about workforce challenges. And obviously, there's a lot since the pandemic has calmed down significantly from where it was here a couple of years ago. The workforce challenges remain significant, both in the hospital sector as well as the skilled nursing facility sector. And I thought, in terms of the workforce, we would start with HR 7623, which is a Telehealth Modernization Act bill. And, that's an important bill that has helped to reduce some of the around virtual care and virtual technologies and allowing the facilitation of those types of consults in more venues and more flexibility around that. And interested in your perspective on the dialogue that's gone on in Washington around telehealth and the support for telehealth in both the rural and urban areas. And just interested in your take on the dialogue both uh, within the House and Senate and your interactions overall in Washington. Do you have some thoughts on that?
Sure. Currently, several of my colleagues in Congress are discussing the future of telehealth. This has been a great tool during and since the pandemic, and rather than driving 3 or 4 hours for a checkup, people can hold a virtual appointment with their physician, which is great, especially in rural areas. I'd say there's a lot of support behind extending the telehealth flexibilities granted during the pandemic, but it is currently up for discussion as to how long any extension would be and in what manner telehealth visits would be reimbursed. I will say, as this issue is negotiated before the flexibilities expire at the end of the year, we'll gain a clear sense of what an extension may look like, and it's an issue that I'll be tracking. So, I benefited from telehealth. Everybody at all ages benefit from telehealth. One thing that I am very cognizant of is in rural areas, there is something to be said for the human touch. It We cannot live in rural areas on the other end of a computer screen and expect the same health outcomes. While I think it's great for checkups and certainly saves time, I don't want there to be two different ways medicine is delivered, and you've got one way for the folks that live in the urban centers and one way for the folks in the rural centers. Um, we still need practitioners in rural America, and these are not mid-levels. Like, we have a lot of mid-levels, which is fine. That is a great option in rural areas, but it should not replace the expertise of a degreed physician. And so, while I do appreciate telehealth, I also want to make sure that we are making sure that we've got those medical degreed physicians in rural Nebraska, so that there isn't a system of haves and have-nots.
Yeah, and I agree with the human touch is definitely a significant component, and I think a lot of the and by the way, I would agree with the fact that I think in the idealistic form, having a high quality physician at the bedside delivering the care of any expertise that would be needed in that scenario and situation wins the day. And what we've seen over the years is a significant challenge in the rural recruiting, even in the primary care corridor. And the other thing that we've also seen from a lot of our primary care physicians, and this is also based on studies as well, where a lot of the primary care physicians are looking. It's not that they don't want to practice in the rural markets, but they don't want to be the person 24 hours a day, 365 days a year. And those coming out of med school today, it's a little bit of a challenge in finding an individual that wants to be that person. So work-life balance is a high demand for these physicians coming out. But beyond the work-life balance, there's a need to practice essentially at the peak of your license or at the top of your license, and that's difficult to do in scenarios where you have no additional resources available to you in the form of subspecialties or support. And so, in fact, talking with the physician who left a rural hospital here a couple of years ago, he said, it doesn't it doesn't work for me to be here and just basically be a gatekeeper and sending my patients to three different cities to get all these different tests and studies. I don't want to be that guy that's just the gatekeeper. I want to be able to provide care in a healthcare facility and setting that is attractive to me, and I can care for my patients in a more comprehensive way. So the ability to augment the workforce and the work-life balance challenges, I think, is very important for those folks, as well as augmenting that with subspecialty support and giving them the ability to keep patients in their hospitals that otherwise would have to be transferred. And so we've seen in scenarios where they have primary care physicians there, but at the end of the day, they don't have the resources, so patients are transferred frequently to the cities essentially for that care. And so we've seen although I completely agree that the ideal situation would be to have boots on the ground physicians, high quality physicians. We've seen it to be difficult in certain areas, for sure. So telehealth has really provided a gateway for a lot of those providers to stay very effective in their rural markets and happy with a better work-life balance and feel like they're practicing as a primary care physician would be in, say, a larger city, like a Norfolk or a Columbus or an Omaha or Lincoln. So I think it's been. I agree with you, and I think there's a nice blend in that scenario. Another question for you on that front is, what about, and talk with some other folks through the Washington side of the equation. There's been some pushback or resistance in terms of people maybe leveraging this in ways they shouldn't be, or overutilization or fraud, essentially. What are you hearing on that front? Has there been a lot of dialogue or concerns around that?
No, I really haven't heard much about that. I know there are enterprising entrepreneurs out there that have nothing to do with medicine that are engaged in trying to figure out how they can make a business out of this, uh, and use technology to leverage, uh, everything that it can do, to do it using artificial intelligence. But there hasn't been a large conversation that I've been involved in, anything with fraud.
Well, that's good. One of my concerns in discussions with these individuals was, golly, don't handcuff the individuals doing some good things for healthcare because there's some bad guys out there. Go track those guys down, take care of them. We'll say so that's helpful. Obviously, we've done a lot of work on that front, and then the nursing workforce, and there's really sort of a two-pronged scenario there. One of which is in the hospitals, which we're working on. But I know you also have an interest in the skilled nursing facility workforce challenges. That's been a topic of conversation, whether it's the RN staffing mandates or the LPN requirements. Working through HR 468. What are you hearing on the skilled nursing facility side of the equation from Washington?
Well, it's an issue that just seems to be getting worse. Like, we have so many skilled nursing facilities in Nebraska that have closed or are thinking about closing because they just can't keep up with it. And last year, the Centers for Medicaid and Medicare proposed a rule setting minimum staffing standards for nursing facilities that will shutter these facilities across Nebraska, all in the name of preserving quality care. As soon as this proposed rule came out, I worked to understand the impact of this rule in Nebraska, and I immediately sent a letter to CMS with other members of the Nebraska delegation. Less than 1 in 5 nursing homes in the nation can meet all of the requirements in this rule. In Nebraska, that's less than 1 in 8, or 12%. One of the requirements under this proposed rule is the presence of a registered nurse on site 24/7. There are literally 9 counties in rural Nebraska that don't even have a registered nurse living in the county. And so this is one of the most glaring examples of a one-size-fits-all federal mandate that will severely hurt care in Nebraska and lead to closures. And many of these residents, they don't have anywhere else to go. They may be in Broken Bow, they'll end up in a nursing home in Lincoln or Omaha without the connection of their family. This is such a short-sighted regulation, and I honestly thought that somebody would come to their senses and this would get headed off at the pass, but it's still chugging forward. Governor Pillen's involved, both Senator Fisher and Senator Ricketts. I mean, it makes no sense, and unfortunately, I think this is where we're headed.
Yeah, it's a huge concern. I know we're in many hospitals in the state of Nebraska and other states, and really it's a concern in multiple states, let alone Nebraska. And Nebraska is maybe a little higher concern than some others, but it's a major issue and a lot of pressure on the hospitals. Which, by the way, although this isolation epidemic we were talking about earlier and loneliness is, although maybe not quite as severe if you're having to be displaced from Broken Bow to a mandated sniff in Lincoln, but when you're isolated from your family, I think there's a token of that coincides with sort of the outlook that an individual would have being in a place they simply don't want to be. And very, similar to patients that don't want to be transferred to hospitals they don't want to be in. So, well, hey, I appreciate your work on that front too, and on at least the hospitals that I've chatted with that are concerned about this would echo your thoughts completely and appreciate your support on that front as well. Um, any discussion on the Washington side of the equation about nursing and augmenting nursing strategies in hospital scenarios or situations, or has there not been a lot of discussion around that?
Well, I think at the end of the day, there has been a lot of discussion about the nursing stuff. Workforce is an issue all over Nebraska. Um, Another way we're seeing technology be utilized is through virtual nursing. If a patient simply needs information, has a question, or can't work with their TV remote, all they have to do is click a button and talk to a nurse virtually. This model also ensures the physician team can be alerted right away if there are any serious issues that come up. So the use of virtual technology is a way hospitals and other facilities can address the existing workforce shortages while maintaining a high level of care. So I actually think technology is going to help us there. Every state is working on workforce strategies for healthcare professionals. I know in Nebraska, we really struggle with behavioral health care providers. We have a plan to get more behavioral health nurses through the Beacon program at UNMC. I personally, advocated for the establishment of the Northern College Division College of Nursing from UNMC on the campus of Northeast Community College. So, this is a major issue, but the need is so great that just recently the state legislature in Nebraska appropriated close to $100 million to set up the University of Nebraska at Kearney as basically another medical school in the state to turn out more rural practitioners, both nurses, physical therapists, OTs, MDs, and that speaks to the importance of the issue.
For sure, and certainly the virtual nursing aspect, which we're involved in, is a big deal. It's a big help for not only urban facilities, but rural facilities, particularly augmenting the skill set and the skill mix for the nursing staff. During the pandemic, we're slated to be, 13, 14 million nurses short here by 2030 globally. And in the U.S., it's substantial. And the other part of that, though, that's oftentimes not thought about is the lack of experience that we've just hemorrhaged experienced nurses here over the last 5 years and have lost a significant amount of experience, particularly at night. And that's both large and small hospitals. So the virtual nursing component really helps to augment that skill set, particularly at night and even during the day. And there are some offloading of various tasks that you can do with that as well. But one big thing is definitely sort of a quasi real time mentoring that can occur with seasoned veteran nurses that can support less experienced nurses. So we've seen significant impacts with the virtual nursing program. So definite support on that would be welcome. So I appreciate your work again on the workforce and the challenges associated with that. Again, the hospitals appreciate your work on that front. One more area of interest that you had brought up that you're working on is the PBM involvement in the rural markets and in healthcare in general, and maybe you could offer some thoughts on and perspectives on the PBM side of the equation.
Well, another difficult one, the PBMs are squeezing out the local independent pharmacies, and they're almost predatory. Let me give you an example. A patient ends up on insulin for the first time. The first 90 days are spent with their local small town pharmacist doing all the patient education about how to administer the insulin And then after 90 days, that prescription is ripped out of the local pharmacy after the education's been done, and it's provided through the mail. What happens when somebody, ultimately, the small town pharmacies don't exist with the PBMs, these predatory, fierce, and really bad actors. They are out auditing every single pharmacy and demanding they be paid back in the event, let's say a patient doesn't pick their pills up in the first 14 days. They pick it up on the 15th day. Well, that prescription then is no longer supported by the insurance company, and then even though the patient got the prescription, the pharmacist has to pay back the insurance company for what they paid for the prescription. It's crazy. And these PBMs are out of control. They're contrary to public policy. They are really, really hurting independent pharmacies in the name of saving somebody money. I assume it's supposed to be the patients, but ultimately it's the insurance companies. And I can't be more clear that I think PBMs are a major problem in healthcare. And in the legislature, I focused my ire on them. And if I ever get the chance to make sure they feel the full pain of what they're doing to rural Nebraska, I'm going to vote for that every single day and twice on Sundays. I am sick and tired of hearing from pharmacists that cannot do business. Who else is going to dispense the medications in Alliance, Nebraska? Who's going to run that independent pharmacy that stays open on Sundays so that somebody can get their prescription after going to a convenient clinic in the middle of the day so they can get that antibiotic? It's just wrong, and these PBMs need to be stopped. And I hope that I have the opportunity in Congress to find a way to stop them.
That's very good take on that, and there's definitely a lot of we've heard a lot about that, sort of in sidebar conversations, of course, in dealing with the hospitals, and some of the hospitals are in the retail pharmacy space, but not a lot of them. There's definitely a lot of local small town pharmacies that are impacted by this, and also are certainly appreciative of your work and efforts on trying to control the PBM side of the equation on that front. Well, listen, Congressman Flood, has been a pleasure to have you on our podcast today, and very grateful for your time and your thoughts coming out of Washington, and more importantly, appreciate your support for the work that we're doing, the work that the rural hospitals are doing, the work that the hospitals in general in Nebraska are doing, and across the U.S. for that matter, as well as the Nebraska Hospital Association. So appreciate all the work that you've done on that front.
Well, thank you. Great to talk to you, and thanks for doing this podcast and for all the work you do in Nebraska.
We would like to thank you for joining us today. Our promise to you, the listener, you will be inspired or at a minimum find value in the information shared in this podcast. Please offer a comment or offer feedback so that we can improve this podcast and better meet your needs. Please remember to share this podcast with others that you feel may get value out of this by listening. And it's always helpful to subscribe to the podcast channel so that you're aware of future episodes and releases. In addition, if there is a rural health topic you would like to have covered on this podcast, please leave us a comment, or you can send an email to pulse@teledynehealth.com. That's pulse@teledigm health.com. For more information or general inquiries, please visit teledynehealth.com.